All right, so we'll now view the strokes according to their blood supply. When we talk about the brain, we actually talk about two kind of blood supplies. There's an anterior blood supply and there's a posterior blood supply. So there's basically an anterior circulation and a posterior circulation. The anterior circulation mainly majorly comes from the carotid circulation, and the posterior circulation mainly majorly comes from the vertebral or basilar circulation. So the carotid circulation, if we can see it here, so this is the anterior circulation, that the one that comes from the internal carotid artery, right? And this is the posterior circulation, which start from the two vertebral arteries, passing from the transverse foramens of the cervical vertebrae, and then coming up to join to form the basilar artery. And before they form the basilar artery, they give you of the posterior inferior cerebellar artery, the anterior inferior cerebellar artery, and then then the two vertebral arteries combine to form the basilar artery, and the basilar artery starts to give you this superior cerebellar artery, goes a little further ahead, and then gives you the posterior cerebral artery, right? So all of this comes from the posterior circulation, and then you have the internal carotid artery. The internal carotid artery goes off and gives you the middle cerebral artery and also the anterior cerebral artery, right? Um, Another thing I want to mention is that the middle cerebral artery goes off and gives you these worm-like further arteries that are called as the lenticulostriate arteries. I'll show that to you here. Can you see this? So can you see that this is the anterior cerebral artery? All this purple part is supplied by the anterior cerebral artery, and then you have this red part supplied by the middle cerebral artery. The middle cerebral artery has a superior segment and an inferior segment. The inferior segment gives off this lenticulostriate arteries, right? Can you see these worm-like lenticulostriate arteries? Right? They supply basically the caudate nucleus, the internal capsule, and globus pallidus and putamen, right? So these are the lenticular striate arteries that come up from the middle cerebral artery, which is all part of the anterior circulation, right? So anterior circulation comes off from the internal carotid artery. The posterior one comes from the base vertebral arteries joining to form the basilar artery, right? Okay, so let's look at the strokes now. So first of all, we have the middle cerebral artery stroke, right? So the middle cerebral artery stroke, you always remember that the face and arm is worse than the leg. Why? Because if we look at the motor homunculus, basically, the middle cerebral artery is here, right? And middle cerebral artery will first affect the face and arm, and then here it will go off to affect the leg. So it will take time to get to the leg, and some of the leg area is spared by the anterior cerebral artery. Right, so anterior cerebral artery also supplies the leg. So some of it will be spared by the supply from the anterior cerebral artery, and it will take time for the leg to come off on as a loss of sensory and motor supply, right? Since the sensory homunculus is right next to the motor homunculus, that's why sensory loss comes up for this in the same pattern, right? So whenever you have a middle cerebral artery stroke, remember that it's the lateral surface of the cerebral hemisphere. It supplies the face area, arm area, language area, which was basically the we studied the Broca's and Wernicke, right? And temporary lobe is also supplied, part of it, internal capsule, the deep branches. I just showed you the lenticulostriate arteries supplies it. Another thing, so patient gets opposite face weakness and opposite arm weakness because you know that the corticospinal tracts cross, right? Um, and the leg is relatively spared. Okay. Patient cannot smile on one side and cannot lift arm on the opposite side, right? So we remember the upper motor neuron and the lower motor neuron. So you know. Okay. Another thing is middle cerebral artery gives you something known as the superior quadrant antenopia, right? Now, superior quadrantenopia, why does it happen? The temporal lobe contains the Myers loop. Okay, I'll show you this first. Okay, so when we look at something, there's an upper visual field and there's a lower upper visual field, and it is read by the opposite side of the retina. So the upper visual field is read by the lower retina, and the lower visual field is read by the upper retina. The lower visual field is read by the upper retina, and the radiations go to the parietal lobe. Okay, and the upper visual field is read by the lower retina, and the radiations go to the temporal lobe, the Myers loop. So after the retina, optic nerve, chiasm tract, lateral geniculate nucleus, and optic radiations, the radiations split into two pathways, right? So they split into this Myers loop, which is the temporal loop, which contains the upper visual field, and the parietal pathway, parietal lobe, which contains the lower visual field, right? And then they go to the occipital cortex, the visual cortex. Now, for example, there's a middle cerebral artery stroke. the temporal lobe radiations will be lost. And that's why you get something known as the superior quadrant anopia, because the temporal lobe contains the Myers loop. Remember, pie in the sky, upper visual field, the temporal lobe visual area is lost, and that's why you get superior quadrant anopia, right? So whenever you have a middle cerebral artery, another thing, you get the language deficit, you get these Broca's or Wernicke aphasia from the dominant hemisphere, right? So if there is stroke of the left middle cerebral artery, you get, which is your dominant hemisphere, you get an aphasia. Otherwise, you don't, right? A right middle cerebral artery, the non-hemisphere hemisphere stroke will give you a hemi-neglect. And a hemi-neglect is basically sort of not even having this feeling that something belongs on the other side. It's not like the patient is blind, but the patient won't shave the other side of his face. The patient will not be able to look at will not be able to judge anything on the other side. That's called hemi-neglect, right? Another thing I want to tell you is that the dominant hemisphere, for example, the left middle cerebral artery is gone. Usually, the left hemisphere contains Broca's and Wernicke's. Therefore, a middle cerebral artery stroke leads to Broca's aphasia and Wernicke aphasia. Whenever you get a Broca's aphasia, let me tell you. So whenever you get a Broca's aphasia is when a patient can understand, but it's very difficult for him to speak. So he'll be like, I want some water, right? That he'll be saying proper sentences, but it will be very, very difficult for him to get the words out. A Wernicke aphasia is basically like a word salad. The patient will be like, I am a helicopter, fly today, tomorrow. Like the patient speaks fluently, but it makes no sense, right? So cannot understand. And just something that the Wernicke and Broca's are connected through these fasciculus called the associate fasciculations, right? That's something I wanted you guys to know. Okay. Um, Okay, so I've told you about the hemi-neglect also, that it's usually when the middle cerebral artery of the non-dominant hemisphere is affected and produces hemi-neglect, like the patient ignores what's on the left side of the body, the left room or the left arm, or he even may only shave one side of his body, right? So imagine like an old man suddenly develops right arm weakness, right facial droop, and cannot speak. Which artery is injured? The middle cerebral artery, right? Okay, moving on to the anterior cerebral artery. The anterior cerebral artery, you think about the medial surface, right? Because the medial surface, can I show you the brain again? Can you see that this medial surface is supplied by the anterior cerebral artery? So look at this. This medial surface is supplied by the anterior cerebral artery. This lateral part of the cerebrum is supplied by the middle cerebral artery. So when you talk about the anterior cerebral artery, it is important to know that the medial cortex contains the leg area. Remember that the anterior cerebral artery is above the knee homunculus, right? When we talked about the homunculus, this part above the knee, this part is basically the anterior cerebral artery. So when the anterior cerebral artery basically goes, you lose the lower limb, you lose the lower limb, right? So you lose the leg motor cortex, you lose the leg sensory cortex, you also lose the paracentral lobule. If you want to know what the paracentral lobule is, you need to go back and look at my brain model video. It will be very, very helpful for you to understand, right? So you lose the motor cortex, you use the leg sensory cortex, and you lose the paracentral lobule. So what do you get? You get contralateral leg weakness, you get contralateral leg numbness, and you get urinary incontinence. Why? Because medial frontal micturition center is affected, right? I repeat this again, you get urinary incontinence because medial frontal micturition center is affected. Okay, there might be some behavior changes like abulia. Abulia is when the patient doesn't initiate anything on his own. Okay, and an exam clue is sometimes like a patient drags the opposite leg. The face is almost normal. And that's how you know if the face is almost normal, you know that the anterior cerebral artery is affected because the leg is affected, right? And then we have the lenticular striate arteries. I showed you that they supply the striatum and internal capsule. You can see that here, right? So they supply the striatum and internal capsule, the globus pallidus, putamen, caudate nucleus, right? Okay. So what happens is if there's a stroke of the lenticular striate artery, these are deep branches, right? They're basically their nicknames are stroke of hypertension. That's cool, right? Okay, so the lenticular striate arteries are known as arteries that are basically responsible for the stroke of hypertension. They supply the internal capsule, the basal ganglia, and the striatum. Now, very important pathology here is any long-standing hypertension will lead to lipoharinosis, and that will lead to a lacunar infarct, right? Um, so basically, what is hyaline arteriosclerosis, lipoharinosis? This is basically a degenerative disease of the small penetrating arteries in the deep brain. It's characterized by the narrowing of vessel walls due to the leakage of plasma proteins and localized lipid and hyaline accumulation, right? Um, so that's a little bit about lenticular striate arteries. Okay, so this gives you the lacunar infarct, right? Since internal capsule rarely carries all the corticospinal fibers, the patient develops without any motor stroke. Without any proper motor stroke, the patient develops without aphasia, without neglect, without visual loss, because cortex is normal, right? This is a very, very important exam distinction to know that you get contralateral paralysis, but there's absence of any neglect, there's no aphasia, there's no visual field loss, and this is because you're affecting the lenticular striate arteries. Now we move on to posterior circulation. When we talk about the posterior circulations, now we're talking about the brain stem. So the part of the cerebellum that's all supplied by the posterior inferior cerebellar artery, the anterior inferior cerebellar artery, the superior cerebellar artery, and then the posterior cerebral artery, right? Okay. So first and foremost, whenever we talk about the brainstem questions are all about crossed findings, right? So they have ipsilateral cranial nerve deficits and contralateral body deficits. That's something you can remember. Whenever we talk about the brainstem, we always talk about ipsilateral cranial nerve deficits and contralateral body deficits. I'll punch this here, right? So you have brainstem questions always about crossed findings, ipsilateral cranial nerve deficits, and contralateral body deficits. Okay, let's go ahead with the anterior spinal artery. So the anterior spinal artery we saw was supplying the medial medulla, right? Since it was supplying the medial medulla, as you can see here, this is your anterior spinal artery, right? So this is supplying the medial medulla, right? This is the part of the spinal cord I showed you on the brainstem. So you can see on this one, you can see the anterior spinal artery here, right? So the anterior spinal artery supplies this medial medullary part, right? At the level of the medulla, the anterior spinal artery supplies the medial medulla. Now, what this anterior spinal artery gives us is if a stroke happens on the medulla, we first lose the pyramid. Since we lose the pyramid, we lose the corticospinal tract and there's contralateral paralysis, right? So if we lose the pyramid, we lose the corticospinal tract and we get this contralateral paralysis if we lose the corticospinal tract. If we lose the medial lemniscus, now the medial lemniscus carries vibration, proprioception, fine touch, right? So you get a contralateral proprioception. And if the caudal medulla is lost, the caudal medulla had the hypoglossal nerve. So the tongue deviates towards the lesion. Why does the tongue deviate towards the lesion? Because the functioning genioglossus pushes harder towards the weak side. Okay, so let's go ahead and look at the medullary area. So here you have the anterior spinal artery. The anterior spinal artery, first of all, supplies the pyramidal tract. So if the pyramidal tract is gone, you're losing your corticospinal tract. So you have contralateral paralysis on the opposite side. That's number one, right? And then you have the medial lemniscus. Now, if the infarct spreads up to the medial lemniscus, if the medial lemniscus is gone, you lose your vibration, proprioception, fine touch. You again get the contralateral loss, right? Because the medial meniscus has crossed and now it's formed the medial meniscus, right? Okay. And then if it goes ahead to involve the hypoglossal nucleus here, if the hypoglossal nucleus is involved by the ASA stroke, then you have a tongue lesion, right? The tongue deviates because you have a hypoglossal cranial nerve 12 nucleus lesion. Why does the tongue deviate towards the lesion? Because the normal functioning genioglossus pushes harder towards the weak side, right? Okay, so whenever we talk about the anterior spinal artery, we talk about the medial medullary syndrome. This is caused, it's just a name of the anterior spinal artery stroke, right? It's caused by infarct of the paramedian branches of the anterior spinal artery or the vertebral arteries. Okay. Um, why is it mentioning the vertebral arteries here? Because the anterior spinal artery is formed by the union of two small branches originating from the intracranial segments of the vertebral arteries. Right? So these two branches merge near the foramen magnum and descend as a single vessel along the front of the spinal cord. Okay, now let's look at the posterior inferior cerebellar artery. When we talk about the posterior inferior cerebral artery, by the way, this is known as PICA pica, and this is known as AICA ica as a short form. Right, so posterior inferior cerebral artery is this most famous stroke, by the way. It supplies the lateral medulla. Remember that um, this line, don't pick a pica horse that can't eat, right? Why do we call it horse? Because you get hoarseness because of this, and why do we call it can't eat? Because you get dysphagia because of this, right? All right, so moving on to basically our posterior inferior cerebellar artery, right? So when you talk about the posterior cerebellar artery, we're basically losing the lateral medulla here, right? So since we're losing the lateral medulla, we're losing all the structures that are part of the lateral medulla. And let's go and look at the structure of a lateral medulla. Now this is the entire area of the lateral medulla, right? So it's going to be the exact same on this side also. So what are we losing? We're losing the vestibular nucleuses, right? So this is something you're losing. You're losing the nucleus ambiguous. This entire nucleus of nucleus ambiguous you're losing. You're losing since you're losing the nucleus ambiguous, you're losing all the fibers that come off of the nucleus ambiguous. So you're losing the fibers that go to roots of nerve 10, the vagus nerve. All the fibers that the vagus nerve takes from the nucleus ambiguous, you're losing them. You're also losing the nucleus and root of nerve 5. So the trigeminal nerve, nucleus, and root you're also losing, right? Another thing, you're also losing this lateral spinothalamic tract, right? Okay, so this is the Snell's picture. I've taken this off from the Snell. So what are you losing here? Can you see that this is your nucleus ambiguous? This one. This is your nucleus ambiguous, right? On Snell. So this is your nucleus ambiguous. You lose that. You lose your lateral spinothalamic tract here. So this is what you lose here. You also lose your vestibular nuclei here, your vestibular nuclei um, here. This one also you lose, right? What else do you lose? You lose your vagus nerve, right? So the vagus nerve is coming off from here. You also lose these inferior cerebellar peduncles, right? Because it's also on the lateral part. You lose this also. You also lose this spinal tract, nucleus of trigeminal nerve here. This is also laterally present. So you're losing all these structures on the lateral side, right? That is something you should remember. Apart from the lateral spinal thalamic tract, all the parts of the lateral things are going, right? So can you appreciate that? That's why it's called the lateral medullary syndrome. So let's go back and see what things we're losing. Losing the nucleus ambiguous. Now the nucleus ambiguous gives fibers to cranial nerve 9, 10, and 11. So you lose all three of these cranial nerves, right? You're losing the vestibular nuclei. You're losing the lateral spinothalamic tract, you're losing your trigeminal nucleus, then the inferior cerebral peduncles and sympathetic fibers are also going. So since you're losing all of this, what are you getting? If you're losing the vestibular nuclei, you're getting vomiting, vertigo, nystagmus. If you're losing the lateral spinothalamic tract, you're losing the pain and temperature from the contralateral body and the ipsilateral face, right? And you get this ipsilateral Horner syndrome. Because of the inferior cerebral peduncle, you get ipsilateral ataxia and dysmetria because that part of the cerebellum is now lost from reality, right? Nucleus ambiguous effects are specific to pica lesions, right? And nucleus ambiguous, since you're losing the cranial nerve 9, you're losing 10, and you're losing 11. What do you get? You can't swallow, you speak in a very hoarse voice, and the gag reflex is lost, right? Because remember, the gag reflex was supplied by the cranial nerve 10, right? And Horner syndrome is very, very important. Horner syndrome is a rare condition caused by the disruption of the sympathetic nerve pathway from the brain to the face and eye. So this is the sympathetic nerve fiber pathway that is going from the brain to the face and eye is affected, and it typically affects only one side of the body, leading to three classic signs. A constricted pupil, you get a constricted pupil, so you get miosis, a drooping lid, which is basically ptosis, and decreased or absent sweating, which is basically anhidrosis. So you get meiosis, ptosis, and anhidrosis on one side of the face, right? Okay, so and all of this is basically known as the lateral medullary Wallenberg syndrome. Just like we had a medial medullary syndrome for the ASA, we have a lateral medullary syndrome named for the PICA. Okay, moving on to the, I think I'll stop the video here because it's 19 minutes long and I'll continue from the anterior inferior cerebral artery in the next video.